Hi, my name is Tamar Brandler. I'm a cytopathologist, and I'm the director of the Division of Cytopathology at Rutgers Robert Wood Johnson Medical School and the Robert Wood Johnson Barnabas Health System in New Brunswick, New Jersey. And I will be presenting on the topic of cytologic and histopathological features of HPV-negative cervical cancers and precancers. The following are the learning objectives for this talk. On completion of the exercise, participants will be able to recognize cytologic and histologic features of HPV-negative squamous cell carcinomas and adenocarcinomas on GYN pap tests and histologic sections. Be able to distinguish clinical characteristics of HPV-negative versus HPV-associated cervical cancers and precancers, as well as differentiating the presenting features of these entities and identifying key ancillary studies in the workup of HPV-negative lesions. Cervical cancer, according to the American Cancer Society, is still the fourth most common malignancy in women. In 2024, the estimates for the United States, based on the American Cancer Society, is that there will be diagnoses of 13,820 new cases of invasive cervical cancer, most frequently in women ages 35 to 44, but being age 50, with over 20% of cervical cancers in women over 65. Who have not had regular screening tests for cervical cancer before that age, and deaths in over 4,000 women from cervical cancer. Of note, cervical precancers occur more commonly or are diagnosed more commonly than invasive cervical cancers, which could be a good thing because that means they're being caught sooner. But the incidence has increased about 1.7% per year from 2012 to 2019 in women ages 30 to 44. However, the incidence has decreased by 11% per year for younger women during that time frame, 20 to 24 years old, and this is likely secondary to vaccination. So before we begin discussing HPV-negative or HPV-independent cervical cancer and precancer, it's important to discuss HPV-associated cervical cancer and precancer, as HPV DNA is detected in virtually 100% of cervical squamous cell carcinomas and precancer lesions like HCEL and CIN 2 to 3. At least according to the study by Pirog and colleagues in 2017, and a number of studies as well. Whereas cervical adenocarcinomas, while majority are HPV related, it's usually 62 to 85%. So not quite nearing 100% like the squamous cell lesions. And when HPV is associated with the lesion, it's because the HPV DNA integrates into the host genome, upregulating the E6 and E7 oncogene expression. Now, important to note is that the HPV vaccine, which is becoming pretty widespread, protects against infection and precancer caused by HPV types that cause 90% of HPV cancers. In the WHO classification of female genital tumors in 2020, cervical squamous cell carcinomas were separated by HPV-associated versus HPV-independent status. While HPV-independent precursor lesions may exist, they were not identified in the data at the time and therefore were not included in or recognized by the WHO. That takes us to case number 1. This is a 41-year-old woman who was HPV negative on the pap, sample, and here we have the pap test, and you can see in several different areas of the pap we have these cells with pretty high NC ratio. The nuclear hyperchromasia is, higher in some areas, more hypochromatic in other areas. The chromatin appears coarse in some of the cells, and, some areas do have a bit more cytoplasm, such as the image all the way on the right side. We have very high NC ratio, and some cells have more, some cells have less cytoplasm, whereas the image all the way on the left and the one in the middle, you can see the NC ratio is quite a bit higher, not much cytoplasm left. If you concentrate on the image all the way on the left side, the cell all the way at the bottom right, you can see irregular nuclear border. It's kind of flattening at the top and kind of angulating at the bottom of the cell. So these are typical features seen in a high-grade lesion, and this PAP was diagnosed as high-grade squamous intraepithelial lesion, or H-cell. The follow-up for this first case, LEAP biopsy, actually confirmed the diagnosis of H-cell, or CIN 2-3, with actual involvement of the endocervical glands, but all margins were negative for H-cell. The following article discusses HPV-independent invasive squamous cell carcinoma of the cervix and displayed 10 HPV-independent squamous cell carcinomas and 435 HPV-associated squamous cell carcinomas. The patients with HPV-independent squamous cell carcinomas were found to be significantly older than those with HPV-associated. They were also diagnosed at a higher stage 3 to 4, and the morphology or architecture of these HPV-independent squamous cell carcinomas were actually heterogeneous, showing different presentations, keratinizing or non-keratinizing, and warty morphologies. This study found HPV-independent squamous cell carcinomas of the cervix to occur at a low rate, 2%, as mentioned before by other studies, and again, presenting at an older age with a median age of 72 versus 49 for the HPV-associated. And as mentioned in the abstract on the prior slide, the higher stage at diagnosis at stage 3 or 4, occurring in about 40% of cases as compared to the HPV-associated, which only 18% presented at a higher stage. In terms of P53 expression, this was variable, and the histology was variable as well, as previously mentioned. And the precursor lesions were significantly less likely as compared to the HPV-associated lesions. So that was something interesting, which, because it was excluded from the WHO, there was no mention prior, but this is something to consider. Here you can appreciate some images of HPV-independent squamous cell carcinomas, as well as precursor lesions that are HPV-independent. So on the left-hand side, you can see this figure 3 and figure 4 from this paper, with the figure 3A and B showing the keratinized growth pattern, and the figure 4 showing tumor cells without the keratin pearls. And on the right-hand side, figure 5 showing HPV-independent precursor lesions, showing different possible morphologies and architectures. All the way on the left-hand side, 5A shows more of a basaloid morphology, whereas 5B shows a differentiated vulvar intraepithelial neoplasia-like morphology. And then the last image all the way on the right is another HPV-independent precursor lesion. And in this study, they found 5 HPV-independent squamous cell carcinomas that were associated with a precursor lesion. And again, the architecture and morphologies were variable, not just for the invasive lesions, but also for the precursor lesions. This study on HPV-negative squamous cell carcinomas of the cervix focused on intraepithelial precursor lesions, as this was left out of the WHO, and they detail 3 pre-invasive lesions and 6 invasive lesions that were HPV independent or HPV negative. Similar to the previous study mentioned about HPV independent precursor lesions. This study found 9 cases, 6 of which also had an invasive component. And if you look at the pictures on the right-hand side, the A and B pictures display an architecture more similar to a high-grade SIL or an undifferentiated basaloid intraepithelial lesion, whereas the image on the bottom displays the architecture more similar to a differentiated VIN or vulvar intraepithelial neoplasia. So it's interesting that there is a range of architectures seen both in the invasive components as well as the precursor lesions, and these morphologies or architectures can overlap with the HPV-associated lesions as well. According to the 2018 United States Preventative Services Task Force Guidelines for Cervical Cancer, screening with high-risk HPV testing alone every 5 years for women ages 30 to 65 years old is an acceptable form of testing. It's important to keep that in mind, that while co-testing is an option where you're having cytology and high-risk HPV testing combined, high-risk HPV testing alone is also a possible recommendation for screening. That brings us to our next case, and that is that of a 31-year-old woman, also with HPV negative on testing. And here is the pap test. And you can see the 2 images. The image on the left, you can see very high NC ratio in some cells, whereas other cells do have still a fair amount of cytoplasm. The chromatin in this case is hyperchromatic and quite coarse. You can see on the cells all the way over in the group on the left are very coarse, or almost like, you could see almost like chunks, or like the chocolate chips of the chocolate chip cookie. And in some of the cells, you can appreciate some nuclear irregularity. They're not 100% smooth. And then on the group on the right-hand side, it almost looks like it wants to be an L-cell with possible hints of halos, but the nuclear size is relatively large if you compare with the neutrophil on the left. But the cells all the way at the bottom of that group, and especially the bottom right-sided 2 cells, show a pretty high NC ratio with, lacking quite a bit of cytoplasm, hyperchromasia, and some irregular nuclear border. And this case on cytology was diagnosed as ASCH, atypical cells, squamous cells. Cannot rule out a high-grade lesion because it was not enough, qualitatively and or quantitatively for a straight-out high-grade diagnosis. But again, this was a case that tested as HPV negative. However, as it turned out on follow-up, this case on cervical biopsies showed numerous areas displaying high-grade SIL or CIN3. And actually, the immunohistochemistry staining for P16 was positive, supporting a CIN3 diagnosis. Now, that's interesting because the initial testing was HPV negative. That brings us to discussing a study that came out entitled HPV-ish negative invasive cervical squamous cell carcinoma histologic and pap test results, which found 25 women with cervical squamous cell carcinoma with high-risk HPV-ish negative or equivocal results on surgical pathology. And 15 of the 25 had a pap test within 6 months prior to the time, diagnoses of ASCH2 carcinoma, and co-testing was done on 5 out of those 15. So out of those 5, 3 of them were actually positive on the co-test, 1 negative, and 1 equivocal. raising the possibility of fluctuating HPV positivity over time. So Alexander and colleagues in this article suggest actually that P16 positivity in HPV-ish negative cases is likely a false negative, and P16 is a reliable surrogate for high-risk HPV, meaning that the HPV-ish was the false negative rather than the P16 being a false positive. So that's something pretty interesting to note, and a number of studies out there actually do mention that P16 is a reliable surrogate for high-risk HPV. Another thing, as an aside, this study mentions is about high-risk HPV-negative cases and the possibility of them increasing with HPV vaccine effects. And I guess time will tell on that front. But I think just really important to keep in mind is, what is happening in these situations where one test is negative and the other one is positive in terms of HPV or a surrogate for HPV. 5.5% to 11% of all cervical cancers are either true negative or false negative for HPV detection. And these HPV negative or independent cervical cancers are typically diagnosed at advanced FIGO stages and display poorer prognosis. True negative HPV independent cancers are mainly cervical adenocarcinomas, as we had mentioned previously. False negative HPV independent cancers can be due to several factors, including histologic misclassification, latent HPV infection, disruption of targeting fragment, non-high risk HPV infection, and HPV testing methods. Here you can see a table for cervical adenocarcinomas and the HPV positivity rates. The first item on the list is endocervical or usual type, which make up majority of cervical adenocarcinomas, up to 79%, and majority, if not all, are HPV positive, or 80 to 100%. Below that, you can see the intestinal type, which is only 3 to 8%, so it's pretty uncommon percentage of cervical adenos, but majority, if not all, are HPV associated. Bringing you down the list to the viloglandular and signet ring cell types, these are always HPV positive, but these are extremely rare subtypes. The endometrioid subtype, on the other hand, can be divided into from squamous columnar junction zone, which are typically HPV related, and from the upper endocervix to the lower uterine segment, which are typically HPV negative or HPV independent. The gastric subtype of cervical adenocarcinoma is also typically HPV negative. And while these are rare, they could make up to 10% of cervical adenocarcinomas and are important to know about. Clear cell, serous, and mesonephric types are also typically HPV negative, although the clear cell and serous type can be up to 30% HPV associated. Here you can appreciate some of the cytomorphology and histology of the HPV-independent cervical adenocarcinomas. First, on the top left, we have the gastric type, which typically can display either tubular, complex, or branching glands with dilation and papillary infolding and a desmoplastic stromal response. You would have mucinous epithelium with clear to eosinophilic cytoplasm, round to oval nuclei with delicate diffuse chromatin and conspicuous nucleoli. You can see in the cytology images the foamy cytoplasm, and in the histology images you can see the complex branching glands. You can have well-differentiated areas lacking atypia and categorized as minimal deviation adenocarcinoma, or areas with moderate to marked cytologic atypia. And immunohistochemical markers can aid in the diagnosis. These tumors are typically MUC6 positive and negative for ER/PR, and P16 is typically negative. On the top right, you can see a clear cell type, 2 images, a lower power and a higher power, and as you would expect, you would have cytoplasmic clearing in these cells. Clear cell adenocarcinomas typically have a bimodal age distribution with a mean age of 26 and then 71 years old. In the past, cases occurring in the younger patients were traced to DES exposure in utero, but it may develop from an ectocervix adenosis, endometriosis, or tubeo-endometrioid metaplasia of the cervix. On the bottom left, you can see the serous type, which can look like serous of any other origin. With the hobnailing cells, you can have these columnar cuboidal cells with the eosinophilic cytoplasm and bizarre or multinucleated nuclei with prominent cherry red nuclei and brisk mitoses with atypical mitoses. These are typically high grade, and you want to be sure whether or not it actually originated from the cervix. P16 will stain positive despite its HPV independent, so that's something else important to keep in mind. On the bottom right, you can see the mesonephric type, and you can see in both the cytology and the histology images, there are some eosinophilic secretions or hyaline globules, which are pretty characteristic. Typically, these tumors display either KRAS or NRAS mutations, and they too can have several different types of architectures, including tubular, ductal, papillary, and so on. Important to note for the mesonephric type is that marked nuclear atypia is not seen in these tumors. Some of the immunostains common for this subtype would be calretin, vimentin, CD10, and PAX8 positivity. P16 is typically negative or seen as cytoplasmic in this lesion. So, in summary, cervical cancers and precancers are most commonly HPV-associated tumors. Rare types of cervical adenocarcinomas and even fewer squamous cell carcinomas and precursors have been found to be HPV independent. And as you have seen, sometimes it is a false negative. HPV independent lesions tend to occur in older age and at a higher stage as compared to HPV associated lesions. HPV-independent cancerous and precancerous lesions of the cervix can display morphologic overlap with HPV-associated lesions and may not be able to be distinguished on morphology alone. P16 may be positive in HPV-independent tumors, again, whether it is indicating that it was a false negative HPV testing or, in fact, it's not associated with the HPV in that moment, and it is P16 positive, but HPV negative remains to be seen. In conclusion, while primary high-risk HPV testing has become an acceptable screening method for women ages 30 to 65 years old, it is important to consider that cervical cancer and precancerous lesions may be missed without cytology testing, co-testing, or primary testing. Despite the rarity of HPV-independent tumors, these lesions are clinically significant as they typically present at advanced stages with poorer prognoses. Thank you so much for your time and attention.